Ladies and gentlemen, welcome back to MedSynapse, the podcast where we connect you with the leading experts in the medical world. Today we have an esteemed guest joining us to discuss on steroid-free treatment. Please meet Dr. Mihika Noronha, a consultant dermatologist known for her exceptional achievements. With a distinguished academic journey encompassing MBBS MD DNB from St. John's Medical College, Bangalore, India, Dr. Noronha stood out as one of the top postgraduates of her year. Her groundbreaking research in immunodermatology earned her an award at a national conference. Currently practicing at Planet Skin and various reputable hospitals in Pune, Dr. Noronha's expertise and compassionate care have positively impacted numerous patients. Her passion lies in exploring the fascinating realm of immunodermatology, focusing on the intricate interactions between the immune system and the skin. She recently presented a compelling paper at World Congress of Dermatology in Singapore, where she discussed the application of tofacitinib with DPCP in treating alopecia totalis. Today, we're honored to have Dr. Mihika Noronha with us on MedSynapse as she shares her experiences and vision for the future of dermatology and immunodermatology. Welcome to the show, Doctor.
Thank you so much.
Thank you. So, without further delay, let's dive into the discussion on steroid-free treatment. Could you explain what exactly we mean by steroid-free treatment in dermatology?
So, most people who are not very experienced in dermatology divide skin conditions into either infectious and non-infectious diseases. And the treatment of choice in a lot of these non-infectious diseases tends to be steroids, either in the form of oral, IV, intralesional, or topical steroids. Now, the range of steroids is very useful, very fast acting, but they come with a wide range of side effects as well. So the point of non-steroidal drugs is to reduce the side effect profile, and we have older drugs that have been used in rheumatology as well as newer drugs coming in right now, and these are also the same way can be used orally, topically, or parenterally.
Thanks for the explanation, Doctor. Now, let's talk about the side effects. What are some of the potential risks and downsides of using topical steroids for an extended period?
So we can, in terms of two things. One is the effect on the skin itself, and then the other is the effect internally, because the skin is the largest organ of the body, so the area of absorption is quite high. So if we look at just the skin, because steroids are primarily immunosuppressant, you have an increased risk of infections, both bacterial as well as viral. Then there is thinning out of the skin or atrophy. Pigmentary changes, which is lightening of the skin, which is more pronounced in skin of color. Then you have flare-ups of acne and rosacea, particularly on the face. Thickening of the skin, which we call hirsutism, process depending on the area. And then if a large area is involved and you use a more potent topical steroid, it starts showing its systemic effects. So you can have decreased bone density or osteoporosis. You can even have Cushing's syndrome, and if it's used around the eyes, you can develop cataracts or glaucoma. Now, these are just the side effects of using the steroid. Now, suddenly withdrawing the steroid, you can have withdrawal symptoms. The skin becomes red, the skin becomes irritated, and there can be worsening of the underlying skin condition. And lastly, steroids have a phenomenon known as tachyphylaxis. So, the longer you tend to use a steroid, the less it starts to burn. So, you end up using a more potent steroid at a higher dose.
It sounds like there are certainly some concerns with prolonged steroid use. So, what alternative treatment options are available for dermatological conditions that traditionally require steroid-based medications?
So, all our knowledge of alternative treatments for steroids came from the field of rheumatology or immunology. So, some of the older drugs were initially tested in rheumatoid arthritis. So, you have methotrexate. You have calcineurin inhibitors such as cyclosporin and their topical forms like tacrolimus and pimecrolimus. You have even older drugs such as dapsone, thalidomide, colchicine, hydroxychloroquine, all of which are still in use and are used for a wide variety of conditions. And then you come to the newer agents. These are biological agents, anti-CD20 like rituximab, TNF alpha inhibitors, interleukin inhibitors, and the smaller molecules like PDE4 inhibition, apremilast, JAK inhibitors, mitogen activated protein kinase inhibitors, Bruton kinase inhibitors, and tyrosine kinase inhibitors. These are relatively new. There is also a very, very ancient therapy which has evolved over time, which is phototherapy, and is extremely effective as an alternative to steroid or even an oral steroid.
Now, in terms of effectiveness, how do these steroid-free treatments compare to the traditional steroid-based ones when it comes to managing common skin conditions?
So, the important thing to remember is for a drug to be passed, there are two kinds of studies that we do. The first kind of study measures its efficacy against a placebo, and the second one is it measures its efficacy against the standard of care. Since steroids are one of the earliest drugs in dermatology, most of the newer drugs were tested first against it, and as we develop newer and better non-steroidal alternatives, they were tested against these newer non-steroidal alternatives. So whatever drugs we have are almost as efficacious, if not better, than the existing modalities. For example, one of our most dreaded dermatological disorders to treat is Stevens-Johnson syndrome or toxic epidermal necrolysis. And traditionally, corticosteroids were used to arrest the process. But currently, we believe that cyclosporin and IVIG provide superior results and better outcomes in terms of reducing mortality and reducing the duration of hospital stay. In alopecia areata, tofacitinib and ruxolitinib, which is a topical JAK inhibitor, have shown regrowth even in those cases which have been refractory. So we've used steroids, we've not had regrowth, but with these drugs, we're having regrowth. And particularly in pemphigus patients, the introduction of rituximab has been a game changer in terms of reducing the complications of the pulse therapy. DPCP, dexamethasone and cyclophosphamide pulse, which was the standard of care, was associated with a lot of comorbidities, diabetes, osteopenia, permanent infertility. The introduction of rituximab induces faster remissions, longer remission, and fewer relapses in these patients without the side effects.
Can you provide examples of the dermatological conditions where steroid-free treatments have been successful?
So I've already named a couple, but I will go into some things that are more familiar to most users. One is atopic dermatitis. So currently we use dupilumab, which is an interleukin 4+13 inhibitor, and it has been proven equally effective with and without topical steroids. So you don't even need to use a topical steroid in the initial phase. So it becomes truly steroid-free. This is the result of 5 clinical trials, including around 120 patients, 4 of them in adults and 1 of them in adolescents. And the dose in adults was around 300 mg every 2 weeks, 200 mg in adolescents. And vitiligo, there have been literature reviews which showed topical Janus kinase inhibitors are similar to topical steroids as well as topical calcineurin inhibitors, which is an older non-steroidal modality in inducing repigmentation. And the good part is this can be combined with phototherapy to get even better results without producing atrophy of the skin.
Thank you so much, Dr. Mihika, for your very insightful responses to our questions. It's truly remarkable. Now, are there certain patient populations that might benefit more from steroid-free treatment options?
Yeah, so it depends on comorbidities actually. So we know the side effects of steroids increase blood sugars, increase lipids. So when we choose these smaller molecules or we choose biologicals, they're extremely targeted. So the side effect profile is less. And they also have fewer drug interactions because they're not working on such a large molecular scale. So those patients who have multiple comorbidities, it's a good option. It's also very good for people who have more than 10% body surface area involvement where, we are worried about the systemic absorption of the steroid. Affordability is the key concern.
Now, let's talk about the challenges. What are some hurdles or limitations associated with using steroid-free treatments in dermatology?
So, like I mentioned earlier, cost is a big issue. The non-steroidal options tend to be much, much more expensive, sometimes going 10 to 100 times more expensive than the cost of a steroid. There are some monitoring and investigations. This is not because they have more side effects, because drugs that have been approved more recently have more stringent FDA requirements or drug control requirements. So even though people might have more or equal side effects because they are older drugs, they don't require so much follow. Also, people are hesitant to use when they feel that the steroids already work. So they're hesitant to try new things. Also, when you live in a country like India, availability of drugs becomes a problem. So we do not have the entire range of drugs that would be available, say, in Europe or the United States, nor the funding to register people in that level of a clinical trial to get those kind of results.
Now, how do dermatologists decide when it's appropriate to use steroid-free treatments versus steroid-based ones?
So one of the things that we look at is how chronic this disease is going to be. If something is very acute, it's going to last a couple of days and we just want to subside. Say something like an insect bite reaction. Probably using a topical steroid has no harm, it acts fast and it subsides quickly. But the moment you're going into something that's going to be long term, something that's going to relapse frequently, and it's going to require sustained and prolonged medication, something where you want long term remissions, you want quality of life, that's when you're going to start looking at the non-steroidal options. And also you have to look at the affordability of the patient. So if you're working in an extremely rural area, the patient is not going to be able to afford a lot of the newer modalities. But even when it comes to that, if we compare, say, rituximab and DPCP, if the cost of a rituximab vial is much more expensive than that of a steroid, DPCP involves admission for 3 days every month, sometimes ranging for 2.5 years. Whereas rituximab, if you use the lymphoma protocol, that's 4 admissions in a month and then you're done. Or if you use the RA protocol, maybe 2 doses and then 1 after 6 months. So modified protocols have 10 doses. But in all of these things, the net cost of treatment becomes lower and you don't have to manage things like deranged blood sugars, hypertensions, and the complications of that, which affect your quality of life.
Thank you so much, Dr. Mihika, for your insightful response. Now, for all our curious listeners out there, are there any advancements or ongoing research or clinical trials exploring the effectiveness of steroid-free treatments?
So the biggest advances that we have now is we're moving into topical JAK inhibitors, and we're also moving into tyrosine kinase inhibitors. So these, even though they're not as specific as biologicals, they can be taken orally. So it becomes more comfortable and easy for patients to take as opposed to conventional biologicals, which were injectable. So ongoing trials, there's a JAD article on crisaborole in morphia. The Mount Sinai Hospital in the US is looking at apremilast versus placebo in alopecia, as well as secukinumab in alopecia. In China, they have a JAK inhibitor known as KL130008. And they are looking at this in terms of psoriasis. And then we look at Philadelphia, which is looking at secukinumab in nail psoriasis. We already use secukinumab for psoriatic arthritis and plaque psoriasis. But nail psoriasis is one of those things which is very difficult to treat. And we used to give intralesional steroids for that. And it's quite painful. So this should be a good alternative. And now we have something known as the Empress trial, which is being run by Russia, which also looks at risankizumab, which is an interleukin-23 inhibitor, and it looks at it in psoriasis.
Thank you, doctor. Now let's switch the gears a bit. I've heard about treating mild to moderate atopic dermatitis with topical PDE4 inhibitors in pediatric and adult patients. What are your thoughts on this compared to using corticosteroids?
So I personally do not have much experience with this because the availability of the drug, which is not widely available in India. Whenever we've had patients, they've had to import it in. But based on the available literature, it's supposed to be safe and effective, and as effective as a topical steroid or even a calcineurin inhibitor in atopic dermatitis. The major complication associated with that is younger children don't tolerate it very well because it tends to sting and burn more compared to the topical steroid. But I can't personally comment on how badly this would affect a patient because I do not personally have patients on it right now.
Thank you, Doctor. Now, before we conclude, Dr. Mihika, do you have any final words of wisdom or advice for future dermatologists?
So, I would suggest looking at dermatology not only as the practice of skin or not only something from an aesthetic or a cosmetic point of view. It's important to remember that the skin reflects our internal health. Very often you can pick up malignancies, you can pick up diabetes, you can pick up a host of other metabolic conditions just by looking at skin health. And when you pick these up, you need to do a thorough clinical examination so you can send the appropriate referrals. So if your plan is to become a dermatologist, you need to have really good grounding in your basic pediatrics, basic internal medicine, and a general knowledge of immunology and microbiology so that you can integrate all these things and the way things appear on your skin.
Thank you so much for sharing your valuable advice and insights with our future dermatologists, Doctor. We truly appreciate your insights today and your expertise shared during our interview. Your contribution is very valuable to us, and we are grateful for your time and for your willingness to share your knowledge on this important topic.
Thank you so much for inviting me. It was an absolute pleasure.
Thank you, Doctor. And before we conclude, we would like to take a moment to acknowledge MedSynapse. MedSynapse is a leading platform that brings together healthcare professionals, fostering collaboration and knowledge sharing. We encourage you to subscribe to MedSynapse to stay updated with the engaging discussions and gain access to a wealth of knowledge from experts in the medical community. Don't miss out on the opportunity to expand your understanding and stay informed about latest developments. That's it for today's podcast. Thank you for joining us. Stay tuned for our next episode. Take care and stay curious. Goodbye.